Have you ever had a hamstring injury? I'm sure many of you raised your hands. I know I have myself. So I had the pleasure of talking with an orthopedic surgeon, Dr. Shane No out of Chicago, who is an orthopedic surgeon and specialist of both surgical and non-surgical treatments of the hip. We talked all about the hamstring, first focusing on hamstring strains, what they are, the grades, treatment approaches, and then working all the way to surgical considerations and surgical options for people with hamstring injuries. This was a really cool one, especially for those of you like myself that have had a previous history of hamstring issues. Give it a listen.
The Prehab audio experience will teach you how to take control of your health through knowledge by optimizing performance, promoting longevity, and keeping your movement system in tune. Welcome to your host, the Prehab Guys.
With me on the Prehab audio experience is Dr. Shane No, an orthopedic surgeon and sports medicine specialist based out of Chicago in the United States. He is a team physician for the Chicago White Sox, Chicago Bulls, Chicago Fire, and Chicago Steel, an assistant professor at Roosevelt University Medical Center, and the section head of the Youth Adult Hip Surgery section. He specializes in hip arthroscopies, open and endoscopic repair of hamstring and abductor tears, shoulder arthroscopy, and arthroscopic and reconstructive surgery of the knee. Dr. No, how's it going?
Great. How are you doing?
Good. Welcome. Really stoked to get you on here. Dr. Chawla and many other people said that you are the hamstring expert.
Hamstrings are actually more common than what people think. I think, we hear a lot about it when treating high-level sports, soccer players, football players. I mean, there are hamstring injuries like all the time. And I think there's a lot of confusion about the hamstring because, frankly, I think it's just not as well known by patients and providers. I think it's a lot more common than people think. So I think the hamstring is, I would say the forgotten muscle of the thigh. And I think whatever we can do to kind of bring more awareness and education as well as preventative strategies for the hamstring, I think it'll empower people who are both treating and patients who are suffering from it.
Yeah, everyone gets focused on what we can see in the mirror, right? The quads in front.
That's right.
So speaking about, you're right. The hamstring injuries are very common, especially in professional athletes, but even with the common people as well. I guess that'll just segue into what are some of the more common injuries that you see, hamstring injuries that you see, and I guess kind of discuss the different types of injuries that are we're going to see in the clinic and or in the general population.
So I think, the hamstring, we see a lot of injuries they are somewhat seasonal in terms of the time of the year that we see some of these types of injuries, which is kind of interesting because you don't really think of hamstring as being a seasonal issue. But I think we see it a lot like in I'll talk about it in different ways, but let's talk about just like hamstring strains. So a strain basically involves an injury to the muscle and tendon, or commonly in the hamstring, the muscle tendon junction. And so it's kind of where the muscle and the tendon meet. So just kind of a review of just basic anatomy. Any muscle has to attach to bone. And so you go from the ischial attachment, which is the pelvis, and on the pelvis bone, then it becomes tendinous, and then it starts to blend into muscle. You get to the muscle belly. And then as it courses down the back of the leg to the knee, then it becomes tendinous again as it attaches to the proximal tibia or to the upper end of the tibia or the shin bone. And so anywhere along the course of this entire unit, it could become injured. So it could be injured at the ischium where it totally avulses or rips off the bone. It could be injured at the muscle tendon junction, which is the most common sites of what we call strains. It can occur at the muscle belly itself, or it could be lower as you get closer to the knee, although not quite as common.
Got it.
And so you can think about it in terms of location. You can think about it in terms of grade of injury. Most people describe strains as three different grades. One is a grade 1, which is like a muscle pull, or you hear people talking about pulling their hamstring. A grade 2 is a partial tear in the muscle, and a grade 3 is a complete tear of the muscle. And the reason why we use this grading system is that it gives you some sense as to how long it's going to take to recover and how long it's going to take to go back into sport. For example, like, when we're talking about professional athletes, the first thing the reporters are going to ask is, is it a grade 1, 2, or 3? Because they want to, in their own mind, get a sense as to how long it's going to take this athlete to get back to playing games.
And what is that typical time frame like? Just say we're talking the professional athlete. If they have a grade 1 hamstring strain versus grade 2 versus grade 3.
Yeah, so a grade 1 is usually just a muscle pull, and so that could be, usually a few days or so before that gets better. A grade 2, where there's a partial tear, could generally take a couple of weeks. And grade 3, depending on how severe it is, could take several weeks or even months sometimes to recover. I guess the easy way to think about it is grade 1 is usually going to be within a week. Grade 2, generally about 2 weeks. And grade 3 is going to be more than 3 weeks.
Got it. That's a really good distinction for a lot of the people listening here. Very easy way to think of the different grades. I think I guess we'll talk about, so you talk about seasonality when it comes to hamstring injuries. That's super interesting. So you're saying based on the seasons, is this for a particular sport? Like we're saying football, soccer? Are you saying like preseason, postseason, or going to dive into that a little bit more?
Yes. So I think it's more related to like preseason, sports. For example, like, I think we probably hear the most about football. And we always hear a lot around like preseason, as the athletes are coming back from not playing and kind of getting back into shape to be able to play at a professional level experience. And it's usually during that preseason where people start dropping like flies because of injuries. And hamstring strains are very commonly injured for a couple of reasons, but usually as the athlete increases the volume of their activity, as well as the intensity of their activity, which is why I think preseason is more likely to be the moment in which people will start having hamstring strains. And I think part of it's related to conditioning, part of it's related to preventative type strategies to help with hamstring injuries. And there are certainly ways to treat it, either before, during, or while people are dealing with hamstring injuries.
Yeah, it's almost like the preseason's too fast of a ramp up, and people need I don't want to call it a preseason, but have a solid conditioning base before even getting into the high speed stuff. In a preseason environment.
Right. And hopefully the trainers can help with some of these types of strategies, because I think, as you mentioned in the beginning, like, there's so much emphasis on, quad, hip flexor. We often forget about the posterior kinetic chain. And that's where the real problem is. If there's a significant difference between either side to side or front to back, meaning the quads way overpower the hamstrings in terms of like both size and strength, I think that's where we're kind of setting ourselves up.
You talk a little bit more about that front to back difference in quads and hamstrings and how the muscles are different from each other, to the casual observer that may not understand the relationship between the two.
Well, yeah. So the hamstrings are really important, in terms of like, eccentric motor control. And so while the quads may give you a lot of strength, the hamstrings help to both generate some of this explosive force, but also kind of helps to slow you down as well. And so, and a lot of times you'll hear these injuries occur, with like sprinting or lunging or jumping, because in these situations, what happens is that the hamstring may overstretch much quicker. That then leads to injury. And so I think a lot of times, if the quad overpowers it, and let's say you've got a really strong athlete with like overdeveloped quads and weak hamstrings, that they're gonna, it's almost like the quads are the gas and the hamstrings are the brakes in that situation. and the gas is too strong,
Yep. I love the analogy. Got to work on the brakes before pumping the gas.
That's right.
Yeah.
What are your thoughts? You agree with that, Mike?
Oh, 100%. Especially when it comes to any sort of, you said, high-speed things. Like typically, we're going to see them when people are sprinting, doing some sort of a jumping motion. So eccentrically, to kind of even back up, is a lengthening muscle action, and then a concentric is a shortening muscle action. So if we think about our knee, and say we're kicking a soccer ball, and our knee is going to be straighter, the muscles in the back are getting longer. So that's an eccentric action for the hamstrings. And that's basically kind of what we're doing when we're sprinting too. So those are the things that are going to slow down our knee from getting straight. That's what Dr. No was mentioning for the sprinting in particular. That's one of the common reasons or mechanisms of injury when it comes to hamstring strains. So volume intensity, that's something to keep in mind. It's going back to hamstring strains. We talked about why they're so common. You briefly talked about the quad to hamstring ratio. I guess muscle strains in general. This is a question we had from someone on Instagram. But why two joint versus one joint? Kind of explain how that may predispose a muscle like the hamstring to higher incidence of muscle strains.
I think like you mentioned, the hamstring and the quads and the rectus muscles both span the hip and pelvis as well as the knee. And these muscles are more prone to strains than anything else, and I think in part, it's basically the two joints have to be considered when you're doing some of these movement patterns, because if the joints are in different positions, it can either make it excessively long or short. For example, as you mentioned before, like sprinting, when you have both the hip and the knee in extension, is different than when you're squatting, where the both the hip and the knee is in flexion. And so these muscles have to coordinate some of these differences between two joints, which I think is a little bit more complex than a muscle that only spans one joint.
Awesome. And then going back into, we talked about the different injuries. You mentioned a grade 3 injury is a complete tear of the hamstring. And then you said based on the severity of it, you'll have to do surgery or not. I guess what are some of the things that, you're looking at to determine, okay, this person has a grade 3 tear. Do they need surgery or not? What are some of the factors that influence that decision making for you?
So for me, the surgical cases are the ones in which there's injury off the ischium or the pelvis. And so if there's a complete tear from the hamstring as it originates from the pelvis, or what we call the ischium, some people like to refer to it as the sit bone. If that is torn, typically the rule of thumb is if it's more than 2 tendons and more than 2 centimeters of retraction from the bone, that these should get fixed. Now let's go back to the seasonality, Mike. I would tell you that we see a lot of this in the summertime because of water skiers and water skiing. So we're going to shift gears a little bit because these are more like hamstring tendon injuries than they are hamstring muscle tendon strains. Mm-hmm. And so I don't know what it's like in California, but in the Midwest and Great Lakes region, where there are a lot of lakes, we've got a lot of people that like to water ski. And the rule of thumb is that if it's between, if you're on a water ski and you're holding on, and the boat is accelerating forward, basically your hamstrings are keeping you in that squat position as you're getting up off the from a stationary position to a moving position. And so your hamstrings are working to kind of keep you in that seated position so you can stay on the skis and not fall over. And basically the hamstring is counteracting the acceleration that's going on the boat that's moving forward, and the hamstring is almost kind of keeping you back down in a sitting position. Does that make sense?
Makes sense, yeah.
And so and the problem is that the boat is going to be much stronger than the hamstring, and so the boat's always going to win.
Yeah.
And so that's when we see these injuries.
So is it typically when I've only tried water skiing once? I hate to admit I was horrible at it. I probably only got up once. I was so frustrated. Um, but I assume it's in the part when, like you're saying, someone's seated, the boat's accelerating, and then my guess is their trunk and their body gets thrown forward with the boat, but then their knee goes into a straight and extended position. Is that typically when they're getting these injuries, or is it a different part of that's when?
Yeah, exactly. And so, and the thing about these types of injuries, it's very memorable. I mean, oftentimes their boat's going to stop, they're going to get pulled out of the water, and there's no more water skiing after that. I mean, they're going to have, most people say they feel a pop, or it feels like someone took like a bat to the back of their hip. It's kind of like if you have an Achilles tendon rupture, same thing. Like it's a moment that you won't forget.
What is it that makes that one? I think if I heard you right, you said more of an avulsion coming off the bone. In terms of the different, like muscle belly or muscular tension strain, what's the difference between, I guess, that mechanism, or how the skiers are having those injuries versus, your sprinter or something like that?
I think these are more traumatic in nature. I think the energy is much higher than our sprinting athletes, and I think that they happen kind of at a much quicker velocity. Do you know what I mean? And so it's with sprinting, it's while you may sustain these injuries when stopping yourself from sprinting or landing from a jumping position, for example, like this is like basically it's a very traumatic injury from essentially your hamstring trying to keep you from getting catapulted forward by the boat.
Yeah.
And so I think that the nature of it is so much more significant that the injury happens to occur where when you think about it, like the attachment of the tendon to the bone is usually much stronger than that between the muscle and the tendon itself.
Mm-hmm.
You know what I'm saying?
Yeah. Well, because of that quick, something to do with the amount of force and how quick it is.
Exactly.
It's tearing there. That's interesting. And those, you said, are people, you said if there's 2 different hamstrings or 2 centimeters, you're doing surgery with them. Is that correct?
Correct. That's kind of the typical teaching. For example, like, if I see patients in the office, they're like, look, I went skiing over the weekend. I went water skiing over the weekend. The boat tried to take me out first time in the season. I heard a pop, stopped, swelling, bruising, couldn't walk, obviously couldn't water ski anymore. Like, and there's bruising down the back of their leg. Like that is a hamstring tear until proven otherwise. And the thing is that, like I said, these are not forgettable moments. Like they will have very, very swollen, very purple leg. And the MRI will confirm it, and those need to be surgically repaired. Now, let me just touch on real quickly, Mike, on the other season that we see some of this stuff in, and that is in the wintertime, at least in states where there's snow. And so,
at least in states where there's snow.
So, and the problem is that, so in the summertime, we see like, young active people water skiing 20s, 30s, 40s, 50s.
Yeah.
But in the wintertime, we see when there's snowfall and there's ice on the ground, we see kind of little old ladies that slip and fall and tear their hamstring. And so these patients are usually 50s, 60s, and 70s. But it's the same mechanism. It's kind of a quick, high velocity injury in which the muscle basically, or that I should say, the tendon pulls off of the bone. Despite the fact that they're older, I mean, the hamstring is still important in terms of having a fully functional hamstring to go about your day-to-day life.
Yeah, I'll say in California we do have snow. I'm here in LA, 2 hours away. We get those, but I'll also say to that kind of stereotype of a person, we also get, I've had 3 patients, walking the dog.
Yeah.
For that older female, classification, walking the dog pulled, slipped. That'll happen, seasonally. It's always 70 or so in LA.
Yeah, that's right.
Yeah. Okay, so say they make the decision that this person needs to have surgery. What does that look like? How does the surgery work for these people? Talk about how, I guess in more simple terms, how you're reattaching that thing that is ruptured back to the bone, and then we can maybe talk about what rehab looks like for them in timelines.
Okay, so as I mentioned before, the typical traditional teaching, at least going through residency and school and things like that, is again 2 tendons more than 2 centimeters. Those patients, go ahead and fix them. But I should tell you, Mike, the indications are evolving somewhat in terms of treatment of hamstring, and there are a lot of patients with what we call these high-grade partial thickness hamstring tears that are being considered for surgery, I think more than what was being considered like 5 or 10 years ago. Okay. And you might see a lot of these patients. A lot of these patients are, 40s, 50s, 60s. A lot of them are runners, to be quite honest. And they may just have kind of attritional kind of start wearing of the hamstring origin from years of kind of repetitive overuse. And while their hamstring tears may not be as dramatic as the acute ones that we were previously talking about, for patients who want to run with any significant hamstring injury, it is nearly impossible to do it.
Yeah.
And so with those patients with these high-grade partial tears, if they failed traditional conservative treatment, therapy, injections, and so forth, and they cannot run, and the MRI shows this high-grade partial thickness tear, these days we are actually recommend fixing them.
Awesome. Yeah, I'll be honest, those are hard to treat, the proximal ones, the chronic ones.
Yes.
Especially because these runners aren't going to stop running too.
They're not going to start running.
That's the hardest part of it. They're not going to stop. Only if they have surgery where they're going to stop, where they literally can't run.
Right, exactly.
It's really hard to tell them. You really can't tell a runner to stop running.
Right. So what do you think, Mike? What in your experience, like at what point do you say to a patient like this, and I know you're thinking about someone in the top of your head right now, what is the threshold for me to say, look, let's get an MRI, let's consider doing either injections and maybe consult with someone about fixing it if there is anything significant found on imaging?
Yeah, so I guess it depends if someone's coming in. I don't know if physical therapists in Chicago have direct access.
Yes.
Or so if someone's coming in direct access, my general rule of thumb for everyone is let's see if we're making improvements about a month in. If we're not making improvements, then for sure you need to go see someone. If we're making improvements, that means we're on the right track and we can keep making adjustments to their plan of care from there. But if someone's not making improvements, that's when it's like, okay, we need to go see someone else. Maybe I'm missing something. Maybe there's something else going on there. And I know for me, just in general, definitely for that person that could potentially respond to rehab if they really, really, aggressively committed to it and or surgery, it's like, look, I'm sure there are things that we can do to make you stronger. I'm not sure. I know there are things we can do to make you stronger. I know there are things that we can do to make you more flexible. I know there are things that we can change in your mechanics. But if we're doing all these things and you're still not able to do whatever it is that you want to do, run 10 miles, not 5 miles, especially for these runners, then it's like, then we have to think of what the next step is. I can only do so much. You can only do so much.
Right.
That's usually the conversation we'll have. If it's achieving their goals, great. Then we can stick with this. But if it's not doing, that high level goal that they want to do, then we have to, go down the route. And then I'll refer to one of the orthopedic surgeons here for them to then have the route. Because that's on you guys to say, well, are we going to do biologics? We're going to do surgery, and then have that conversation with the patient.
Yeah, I would agree with that, I agree with you. And I think the challenging thing is that if we don't see much on the MRI, then it's hard to compel to do anything invasive, meaning surgery. If there is even a partial tear, I think that is warrant investigating if they, again, as you said, aren't achieving what they were doing or what they want to do. I think for me, it's real easy. If you're a runner and you can't run and there's something going on in the MRI, even if it's a partial tear, like we should probably consider scoping it.
Yeah. And when you say scoping it, what is it exactly that you're doing for the partial tears, like in the operating room?
So going back to surgery for these things. So traditionally they've been done with an open surgery, but now with these kind of tears that we've been talking about, these chronic high-grade partial tears or partial tears, a scope or an endoscopy would be considered. And so with these patients, we'll put in about 3 or 4 little incisions about size of your fingertip. We put in a microscopic camera under the subgluteal maximus space, or the deep gluteal space. It's also been referred to, and basically, clean up any bursitis, usually from the ischium. Find the torn proximal hamstring. In addition to that, because the sciatic nerve is right next to the hamstring, you also want to make sure that you clearly identify that as well. Put in a couple suture anchors to repair the torn proximal hamstring and tie it back down. And that's what we do with the scope. And the open approach is pretty similar. We just make a bigger incision, but it's not huge. It's probably about 4 or 5 centimeters.
Wow.
And again, we locate the torn hamstring. We put in these anchors, weave the stitches through the torn hamstring, pull it back up to bone, and let it heal.
Got it. So you do pull it back up to the bone, and that's where you're anchoring it down.
Right.
Okay. That's cool. Yeah. I mean, so this is a random question that I was going to ask. Hamstring syndrome. So you talked about how close the hamstrings are to the sciatic nerve. How common is that, or is that actually really a thing that you see in clinical practice, where someone's getting true sciatic symptoms from the hamstrings and where they attach, up in the hip, and then treatment options for that? You kind of mentioned it a little bit when you were talking about the scope. Is that something you've seen before in practice?
Yes. And I think we see occasionally if there could be some sciatic nerve irritation. I've seen some cases where there's been so much scar tissue around the hamstring that it basically entraps the sciatic nerve or scars around the sciatic nerve. And if any chronic hamstring tear, if it's been going on for several months, it basically will scar down to the sciatic nerve. And so this is where it gets tricky. And so whenever I see an acute tear, and for anyone listening out there, if you think you've got an acute tear, you should see someone right away for it, because if it becomes chronic, we could still fix it, but certainly the risks go up. It's more difficult. There's more dissection off the sciatic nerve, and there could be the development of nerve symptoms, and that would either include numbness, tingling, or weakness in the distribution of the sciatic nerve.
Yeah, I occasionally will get some butt pain. I had an old history of hamstring injuries. Not really sure what it is. I get it occasionally. That's on my differential list for my own hip. It's annoying. Really,
Too much
real pain in the butt. I know. So that's really cool. Again, and talking about whether you're going to do surgery, or we talked a little bit about biologics. Is that something that you do in your practice? Again, biologics for people that are listening are going to be things like PRP or stem cells, or anything else. Is that something that you're doing with these surgeries? Is that something you're doing even non-surgically, maybe before surgery, or how are you implementing that within your practice?
Yeah, so we do incorporate biologic as a potential way of optimizing healing, and we do it in all the above reasons. We could either do it pre-surgery, and I think that for me the PRP and or stem cells, probably has a role in that case of chronic hamstring. Often they'll call it tendinosis on the MRI, but there isn't quite a tear that you can see. That makes sense? So, Mike, think about that runner. He or she is in 40s, 50s, running their whole life. They're starting to see the mileage slow down a little bit. They can localize their pain in the buttock area. You get an MRI, and there is no tear. There's no partial tear, but they still have pain back there. They may have a little bit of tendonitis and or tendinosis. And in those cases, I think doing a PRP or stem cell could be worth trying. In addition to that, I think in a repair setting with surgery, PRP and or stem cells could help. And we use it from time to time, but I guess I'm not entirely sure whether or not it helps. I think we probably have to do a little bit more investigation to see if adding any biologic injection actually changes the outcome in any way, or is the repair, reasonable enough to do that.
To take and heal. Yeah. I know that's a question, we get a lot on the rehab side, and that's like, well, I don't know anything about that. You got to talk to your orthopedic surgeon about that. Because it's so popular, I think, right now in the media. Everyone hears those terms just kind of thrown around, or hears athletes, for lack of a better word, going PRP or whatever it may be. So it's a very hot topic, I will say that. Right.
And I think there is some interesting potential applications to it, but to be quite honest, I just don't think we have the data on it. I think in general, I tell patients it's not really hurtful. I mean, basically, we're using your own blood products or marrow products. We just don't know how helpful it is.
Mm-hmm. Is it something that say you were to recommend that to someone? I know a lot of times you get multiple doses of it, correct, or cycles. Like you come in once, and maybe a couple of weeks, or I'm not sure how long, you get another one. Is it something that you would expect to see improvements within one? Or is it something that you need to go through a couple of them to be like, okay, is it working or is it not working? Just kind of based on your clinical experience.
That's a good question. I think the short answer is, I'm not really sure. I don't think there's really good information or data on it in terms of, how many to do. In general, we'd say try it, see if it helps. If it seems to help, great. If it doesn't seem to help, maybe try another one. I think we're not quite there yet.
Yeah. Do you think there's going to be any recent, or I won't say recent advancements? What's like on the horizon for hamstrings in general, whether they be hamstring surgeries, hamstring prevention? What do you think is kind of like the next decade where things will be going, in your opinion?
Well, I think in terms of surgery, the endoscopic repair is really, something that's just kind of come online within the past couple of years. And I think that's going to become much more popularized, especially for patients who are, as we're talking about, these very active individuals, particularly runners, that just can't run. I think choosing and identifying which of those patients are good candidates for surgery and which ones are not are going to be, the way of the future, as well as understanding, is there a role for biologics and when do you use it? Do you use it before surgery? Do you use it as an adjuvant to surgery? Or do you not use it at all? I think those are some of the questions that I think will need to be answered. I mean, there's no question in my mind that the hamstring is a critical muscle if you're doing either any running or any explosive type activity. And it doesn't take a lot to keep a runner down if there is a significant hamstring injury. In terms of prevention, I think, if we can get our arms around a little bit more information in terms of some of these athletes that are, let's say preseason or about to start to pick up their volume of intensity of training. And if we're able to identify their strength going into the season, I think we'll be able to target better strategies in terms of preventative measures. Clearly, patients with previous history of hamstring injuries are going to be more prone to recurrent injuries or repeat injuries or injuries to the opposite side. And so those patients will be considered high risk. But I think, as I think you alluded to before, Mike, eccentric strengthening, those Nordic hamstring exercise, I think, hopefully we can come up with a good program for patients in terms of, hamstring prevention strategies, especially for some of these athletes that are prone to these types of injuries.
Yeah, the Nordics are a good one. Super good one. They're so tough. But I think I've seen some studies. The implementation on like a preseason was super low. I want to say it was only like 5-6 reps, but it really reduced the rate of hamstring strains for that season. I think it was in football, like Europe soccer, European football, which is crazy. Like just that little bit of intervention was able to have that big of an effect.
Yeah,
which is awesome. That's again talking about the conditioning of people, even maybe before the preseason, or something that people are incorporating. Athletic trainers and strength coaches are incorporating during preseason to try to mitigate hamstring risk and injuries.
Right. I mean, it makes you think, like, maybe if we got the word out on these Nordic exercises, if we can really change the rate of hamstring injuries, let's say for football or rugby or soccer.
Mm-hmm. Yeah, I think it's getting there. It's at least something now that I think you see someone doing it in the gym, you're not going to just be like, what are they doing? It doesn't look that crazy, because it kind of looks a little weird. Someone's holding someone down, someone's falling to the ground. People have at least been exposed to it maybe a little bit more. And you're right, as long as we can get people understanding the value of stuff like that, especially for people that are competing at a high level. No one wants to injure their hamstring and be out for X amount of weeks or months.
Right.
Actually, quick question on the endoscopic. What is a typical return to play timeline for an athlete if they have that high grade partial tears, like chronic tear, and you guys decide to do an endoscopic repair? What's the timeline looking like for that runner?
It's I interestingly, I had a runner recently who, after 3 months, was like, I'm running like 5Ks and 10Ks at 3 months after repair. But I think that's not normal. Some patients, it can take them like up to 6 months or so.
Okay.
So I would say somewhere between 3 to 6 months, depending on how large the tear is and how extensive the repair is and so forth.
Cool. Well, any other hamstring related topics, I guess, that you want to bring up? That was most of them that we pulled our followers beforehand. We covered just about everything. Is there anything else that you want to talk about in regards to hamstrings or just in general, the hip, anything?
I think a lot of this stuff is related to like neuromuscular imbalance, asymmetry. I think in general, Mike, if we can get a better handle on our prehab, as obviously you're a big proponent of, and understanding more on a quantitative level to what degree there may be weakness, deficits, asymmetry, whether it's through strength, whether it's through movement patterns, whether it's through even surface area, circumference. I think the next age of medicine, at least what we see, and I think in rehab as well, is going to be data driven. And so the more information we have, I think the better decisions we're going to make, the more we're going to be able to identify patterns and problems earlier. And I think it'll be really interesting to see how we can incorporate technology and data analytics into our treatment algorithms.
100%. I couldn't agree more. Data, drives everything. I think right now we're almost at this point where maybe we have I don't want to say too much data. We don't have too much data, but we don't know how to analyze it or best collect it. There's so many different companies doing so many different things and looking at all these different things. And I'm on the clinical side, like you, I'm not on the research side. So I kind of get overloaded sometimes when talking to some of these people, like, wait, how do I actually use this?
Right.
How's it going to change what I do? I only have an hour with this patient.
Right.
I can't, spend 2 hours setting up these markers and do all this stuff.
Right.
For the professional athlete, sure. Like we have the time, we have the resources to do it, but it's how do we get that into, every PT clinic, every sports medicine clinic for the general population. But I guess it has to start somewhere in the sports population. Where things like that start, and then it grows into slowly trickles down into the rest of the population.
Right.
So
Exactly.
Exciting. Definitely exciting. Definitely exciting. Well, awesome, Dr. Nose. Thank you for your time. Let's see this. Where can people find you? Social media and website, in case anyone has any questions for you later on.
So on Instagram, Chicago Hip Doc, and also Facebook, ShayNoMD.com, and LinkedIn as well. So any of those avenues, pretty easy to get a hold of, and so feel free to reach out if any additional questions come up.
Awesome. And I'll link all the social media and the website in the show notes as well for anyone listening. Dr. Nose, thank you so much for your time. Hopefully this season, let's see, summer for you guys. Hopefully you're not seeing too many of those hamstring tears right now up in Chicago and the Great Lakes.
This is the time of year, Mike.
That was awesome. I learned so much talking with Dr. No. I hope you guys did as well. Let us know if you guys like these interviews with orthopedic surgeons. I know me, selfishly as a physical therapist, I really, really enjoy them because I get to ask the questions that I've always wanted to ask and maybe not necessarily have the time to ask when I'm on a short call talking about a patient. But in this podcast form, we can have a discussion, and it really opens up my brain to just so many different things that I haven't been exposed to. So let us know in the comments if you guys like it. Please, please, please rate, review, and subscribe. The reviews really do mean a lot to us, and it really, really helps our podcast. With that, have a good rest of the day, guys.